Dr. Shannon Ruzicki is a general internist and assistant professor in the departments of medicine and community sciences at the University of Calgary. She has a master's in public health from Johns Hopkins University in quality, patient safety, and outcomes research and in epidemiology. Her research interests include perioperative quality improvement and anti-oppression in health systems. Without further ado, I turn it over to you. Thank you.
Thank you. And it's an honor to be presenting to you guys today about some work I've done in equity, diversity, and inclusion as fundamental research skills. Today, we're going to discuss why EDI and anti-oppressive practices are needed in all types of research, demonstrate some ways that you can apply these principles throughout your research process, and then look at how EDI and anti-oppression is important in knowledge translation. Thank you for doing a land acknowledgement. I'm in Treaty 7 in Calgary, which is the present-day territory of the Blackfoot and Treaty 7 people, including the Siksika, Kainai, Tsuut'ina, and Stoney Nakoda First Nations. I aim to use inclusive and first-person language throughout my presentation, but you can always contact me or bring it up during the presentation if you hear or see something you think can be improved. Throughout this presentation, I'm going to use the terminology used in the original papers when applicable, which is not always the most inclusive, but I want to be as true to the literature as possible. I may use the acronym BIPOC, which is an acronym that represents Black, Indigenous, and people of color, which is a very heterogeneous group of people with different lived experiences, but whom all can experience marginalization due to their color of skin or race or racism. So to start, I want to talk about what research looks like when you don't consider equity, diversity, inclusion, and other anti-oppressive practices. So in this study, 3 male investigators screened the social media profiles of their colleagues and classified their profiles as either professional or unprofessional. Potentially unprofessional conduct included pictures with alcohol, inappropriate attire, which they described as bikinis and provocative Halloween costumes, political statements, including those about gun control or access to abortion, etc. And this study led to a massive uproar on what was formerly known as Twitter. Basically, it was 3 men scrolling through their colleagues' social media profiles and making judgments about their Halloween costumes. And so ultimately, this article was retracted. So, at minimum, this is an embarrassment and a waste of the researchers' time. But research without EDI can be have greater impacts than just institutional embarrassment. This is a non-inferiority study that compared the outcomes of screening colonoscopies that were performed by nurse practitioners to those performed by board-certified gastroenterologists. And so this is a non-inferiority study. It wasn't like a randomized trial where you expect that the treatment could be an improvement. They were really just testing to see if nurse practitioners could perform like the basic competency screening colonoscopy. And the idea was to save resources and expand accessibility. So what's the problem? Sounds very good, right? But when you look at the table 1, you can see that African American participants were about 74% of the entire study. And this is an issue because Black patients only accounted for 30% of the patients at the clinic where recruitment was done. And we know that in most clinical trials, whether it's a randomized trial or an observational study, et cetera, Black participants are often underrepresented or under-recruited into these types of trials. And this is even more problematic because Black people in the United States have higher rates of colorectal cancer and a greater mortality from those cancers. So therefore, we should not be entering this higher risk group of patients into a non-inferiority study at a greater rate that they are proportioned into the study, especially when most of the time we see underrepresentation. And so what about the recruitment practices here led to an overrepresentation of African Americans in a non-inferiority study for a procedure, for a disease that they're at the greatest risk of? So did we expose these patients to potential harm, or was there bias in that process? And lastly, this is an example of clear harm from not considering EDI and anti-oppressive practices in your trials. So this is the Made It 2 trial, and they looked at implantable cardiac defibrillators, or ICDs, in reducing mortality in specific type of heart failure. And you'll note that 85% of the 1,200 participants were men. And so this was published in 2002, and it was a positive result that these ICDs were reducing mortality in heart failure. And it was incorporated to all major guidelines and remains in most major guidelines. However, about 20 years later, cohort data started to suggest a single signal for harm in female patients. And this has been pretty consistent. Where they've been finding that women have a lower overall mortality benefit and receive fewer appropriate shocks than their male counterparts, but their inappropriate shocks is equal or greater. And of course, inappropriate ICD shocks are very painful. It's a pretty significant adverse event. And so there's still no mention of sex or gender considerations in the CCS guidelines. And so we still don't really know if the reason that women participants are receiving less benefit and more adverse events from ICDs is because of body size, because of hormonal status, or other factors. And this has not yet been elucidated. So when you are doing your research training, your PhD, your master's, whatever, you get a background in some kind of statistical analysis, the types of study designs. Everyone goes through ethics courses. But why are EDI and anti-oppressive practices not considered a fundamental foundation for most researchers? And I will argue that they should. And it's an ethical obligation of universities and research institutions to ensure that their trainees and their researchers have these skills. And EDI principles should be incorporated throughout your entire project, starting with the conceptualization of your study question right through to dissemination. And these principles apply to all aspects of your project pathway. So it's not about matching, okay, I'm doing study design, so I need to check off these principles. It's supposed to be a longitudinal conceptualization. And so I'm going to go through some of these principles and how they look in the research practice. Starting with perhaps the most important, which is understanding what is marginalization and what is privilege. And I think this is absolutely mandatory. And I have some references and additional links through QR codes on the top of your screen if you're able to use your phone and your camera function to open these links if you would like. So your marginalization and privilege influences your entire study design, the question, the recruitment, the analysis, and the dissemination. Privilege is an unearned advantage that is given to you by society. Privilege is not about how hard you've worked or your personality. And you can have privilege in some ways and not in others. And it's not like a score where you end up with like a percentage of privilege. And it's also not meant to undermine your achievements, but it is important to acknowledge this position that you're in and how that might influence your research works. So this figure is from Dr. Stephanie Nixon's coin model of privilege and oppression. And it really emphasizes how a system of inequality, which is a social structure, can create winners and losers. So people who have advantages and people who have disadvantages because of how systems are reinforced in society. And so you need to think about how the people who may be oppressed and the people who may be privileged, how that might influence your study design and recruitment. And I think this is probably very applicable to the study design for that GI endoscopy study we spoke about. So why were some of the more marginalized and oppressed and at-risk people recruited to a non-inferiority study when we know the opposite is true for most trials and observational data? So what about the recruitment practices, informed consent, et cetera, did not take into consideration that type of marginalization or oppression? And so there are lots of systems of inequality, and understanding where you sit and where your potential patients sit and might not sit will help. And I'll return to this concept a great deal throughout the presentation because it does really influence so many aspects of all types of studies. So for example, Whose voice is represented in your study question? Is it important to you as a researcher, as a physician, as a professor, an academic, or is it important to your patients? Whose voice is not being represented? Looking at your study protocol. So how might marginalization impact the ability to go for extra tests or answer follow-up surveys or being included in a longitudinal study? How does marginalization affect your recruitment? Who is invited to participate and who isn't? Who is not represented well in administrative data? Who do we not consent or approach to recruit? Sometimes even in the eligibility criteria, it'll say, well, the participant has to speak English. And how does that lead to inclusion or exclusion representation issues in your study? How does marginalization affect the participation? And how might, if your population is privileged, how does that influence your results? So if your population is wealthier or whiter and less at risk of certain conditions or certain harms, could your benefits of your intervention be less pronounced in a group that is less at risk? So are we missing something that might be helping other people who have a greater risk? It's very important, regardless of if you're in basic sciences, clinical research, whatever, to learn and acknowledge the history of your field. So it's very standard to conduct a preliminary literature review when you're conceptualizing a study, but I would argue that you should also perform a historical review of your field using an EDI lens. So for example, this is Dr. Marion Sims, known as the father of modern gynecology, and he invented or discovered many procedures and equipment that would facilitate gynecologic surgeries. He started the American Gynecologic Society, and so very popular, very well known, and his research is often cited. There are so many devices and procedures named after this person, but he performed most of his experiments on enslaved Black women without anesthesia. So non-consenting participants who were not afforded the standard of care, which at that time was to anesthetize patients who are undergoing surgery. And so what does not acknowledging that legacy mean when we're recruiting patients in a gynecologic study, for example? And how does not teaching this to our learners or not acknowledging this in our research team lead to kind of a false idea about the nobility of science, that we're above these types of biases and these types of issues? And erasing this history, I think, is really problematic for our learners from marginalized or oppressed groups. So if you're part of a study team that really talks a lot about these primary studies and these primary data from people like Dr. Sims without acknowledging the harms and the history of racism, how might a Black student on your team feel being erased in that way, or hearing only someone's great achievements be exalted over and over again while not acknowledging some of these harms? So I would argue that scientists should have a foundational understanding of the history of EDI in their field. And so to do this, you can perform an EDI literature review. So looking at some of the history of the people involved, who was and was not included, who's included in your primary literature base, and what type of patients might have been excluded, how was that research done or not done? And I think that that can inform how you approach recruitment, how you approach community partners, and create safety on your team. And I will return to this and how to operationalize the results of an EDI literature review later. There's been a lot of discourse about recruiting diverse teams. There's tons of evidence that's growing that there's a value of having diversity on any type of team, in particular a research team. And we know that exclusion of certain demographic groups from research is very well documented. And the contributors to why certain groups have been underrepresented in academia, in medicine, and in research they span the entire career continuum. So, it starts even before someone enters an undergraduate science program. And so what are some ways that we can work to address some of these barriers, starting at even, pre-undergraduate science lectures? Well, can start by recruiting people using sort of these non-typical networks or non-typical channels. So for example, how do we find people for our research teams? Are we asking around other scientists who may look or think like us? Or are we soliciting with intention people from diverse backgrounds? So for example, if you are circulating a research position, you can contact some of these alumni groups or groups that represent underrepresented or marginalized trainees and preferentially advertise or post so that at least your search process includes a wider net of potential applicants and doesn't rely on those existing networks that are quite exclusive. You also may need to build capacity within your research team. So for example, we know that a lack of skills is not a key contributor to the noted underrepresentation of some groups in academia, but you also may need to invest additional time, training, and resources to develop skills among team members who may have been excluded from previous opportunities. So for example, if you know, and we see this a lot, like in medicine especially, we see a lot of nepotism in how study teams are structured. So like, you know, when you're like reading an author list and everyone has the same last name or the first and author of the same last name, and you kind of wonder. I remember one time reading a JAMA article at Journal of the American Association. So like a very prestigious, high impact medical journal. I think their impact factor is like 70 or something, but the first and last author had the same last name. And when you looked at the affiliations, the first author was in high school. So it was actually ended up being the senior author's daughter who was in high school, who was like doing this like big epidemiologic study. And you're kind of like, really? Like I didn't like, so thinking about how someone's resume or skill set may have been influenced by a privilege and marginalization throughout their life, and how those CVs maybe look different, but may reflect similar amounts of skills or similar amounts of potential, and how you may have to invest greater training or upfront time to address that privilege and marginalization that you've seen. And so that's, you know, where socioeconomic status, having physicians or other scientists or academics in the family can really create those networks. So those unearned advantages that we talk about, for example, we know that a lot of networking can occur in very exclusive spaces, like on the golf course or the country club, or in places that not everyone has access to, right? And so thinking about how to recruit and build capacity as part of your plan to increase that diversity. You need to be committed to maintaining the safety of your team. So I think it's not ethical to, you know, recruit a group of Black medical students or Black trainees to your research team and not ensure that the rest of the research team has the skills and capacity to be safe and anti-racist for those students. And so ensuring the other people on your team have an EDIA lens and have an understanding of some of these concepts, so you're not bringing people into a toxic environment. And as the leader of a team, using your privilege as the leader of the team to ensure that everyone is treated well and respectfully is really important. Compensation is a huge issue. So we know that a lot of, especially like the summer student grants, or a lot of even the graduate student salaries are well below a minimum wage and well below a living wage in most of the cities where people train. So for example, in Alberta, the living wage is about $23 an hour. And so if you are asking a summer student, like an undergraduate student, to participate in your research project, and you are paying them minimum wage or even one of those grants where it ends up being a stipend that it equates to lower than minimum wage, you're actually asking people to volunteer their time or work for free on your projects. And that can be really exclusive for people who don't have the networks or the credit score or the opportunities or the parental support to do that. And so thinking about how to write into your budgets or how to find that extra money. I know money is tight. That's always the biggest issue, right? But thinking about how compensation can reinforce these gaps for diverse teams. And yes, the living wage is $23 an hour in Alberta. It's important to meaningfully partner with communities, and there's a lot of frameworks and ways to do this. Community-based, participatory, action-based and oriented research is one. Having patient partners is one. But it takes time, investment, and skills. So if you can't just write an entire grant or an entire project and then come to community afterwards and be like, this is what we did, what do you think? It's really important to start that relationship and start those meetings and work early, and understanding what is important to community members and letting that inform the direction of your research. And sometimes this means that you will not get to do the research that you originally intended to do because it is not a priority for community. And again, how might this have influenced recruitment of the GI study? So partnering with those most influenced or most at risk of colorectal cancer, those who might most benefit from better screening, would that have changed the paradigm of that study? Would that have explained the greater recruitment of Black participants in that study? And so just thinking about that, one way to do this is if looking at the national or local patient-oriented societies or groups for the area that you're most interested in. So for example, if you do research in Alzheimer's disease, have you spoken to people from the Alzheimer's Disease Society of Canada? If your work involves trans individuals, have you partnered with Stepping Stone? Like, have you brought in those community stakeholders or those community groups early? And have you consulted with them in a meaningful way where they inform the study question and the study design? And are you compensating your partners and your community partners appropriately, or are you asking them to volunteer in your work? It's also important to recruit diverse study populations, and recruitment is a very active and key process, not a passive process. And this can lead to a lot of structural exclusion in studies, in registry data, and in trials. And so I'd ask you to carefully consider your exclusion criteria. So for example, we often exclude pregnant people from studies, especially when we're testing new drugs or new treatments. And I really would ask you to reflect on if you could adopt a more informed consent model where you allow pregnant people to decide if the risks of participating in a study are acceptable to them rather than just blanket excluding them. And the reason I bring that up in particular is around the COVID-19 vaccination trials. So when COVID-19 vaccination trials first started, pregnant people were excluded because of concerns about how an mRNA vaccine may affect pregnancy or the fetus development itself. But the issue then became that 77% of the global workforce are women, and the majority of those women are in their prime reproductive years. So even though they were excluded from the trials, there was a very pragmatic and real world gap in that pregnant nurses, pregnant physicians, pregnant healthcare workers did not know if the risks of working with COVID-19 patients in a hospital setting, in a clinical setting, outweighed or how they compared to the risks of taking a COVID-19 vaccination without great data for how it can affect pregnancy in the fetus. So excluding pregnant women kind of left there to be a bunch of women making decisions on their own without any data outside of a trial or a registry where that information could have been collected. So they had to make that decision for themselves anyways. And so I wonder if we could have had more data about the safety of COVID-19 vaccinations in pregnant people earlier by allowing people to select for themselves if they wanted to participate in that trial, knowing that there was like an emergency and a life-threatening thing going on. And then similarly, carefully looking at your inclusion criteria. So often it'll say consenting patients only, but how does bias influence who we approach for inclusion? So if you're like a study coordinator going around trying to decide like, should I recruit them or them? People don't want to use language line. They don't want to use translation services. They don't want to talk to people who seem like they're not going to get it, or people you anticipate are going to say no, because, recruitment is a really big challenge and it takes a lot of time and effort. And so these issues are not insurmountable and they can lead to bias and exclusion in studies. Similarly, how does a need for housing or in-person follow-up influence recruitment? And how can that then bias your results? If our most at-risk and most vulnerable patients for disease are not being included in trials, are we missing effect sizes? Are we biasing our data? And if we're excluding people with use disorders, whether explicitly in the inclusion criteria or in our recruitment processes, because we say, well, they live on the streets or they use IV drugs and there's no point in approaching them to the trial. So how does that influence our understanding of things like endocarditis treatment or other diseases or conditions that could be modified by a relationship to substance use, et cetera? And then again, learning the history of your field kind of comes back in this. So Why are some groups less likely to participate in research? It might come from the researcher side. Sorry, I went back. But it might come from the researcher side where we're excluding those people in our inclusion and exclusion criteria, or we're not approaching those people in terms of bias in like that kind of unconscious bias in the process. But if you were, for example, a Black woman in the US and you had heard about these sort of studies performed on non-consenting enslaved Black women without anesthesia, how would that make you suspicious of academia and the healthcare system, et cetera? How could those previous experiences influence your willingness to just hand your consent over to a researcher who you don't know? And then how does that influence the generalizability of your results? So if you don't know how groups have been harmed by researchers or research in your field, then you can't overcome or build trust and then increase recruitment of those participants. It's also important to report and collect your data accurately. And by this, I mean isolating your variable of interest. And I know you're a lot of researchers and you probably know a lot about confounding and all of these things, but this is actually really important when sorry about that, when it comes to diversity and demographics. So for example, a lot of studies report the influence of race on an outcome, or, the table 1 will list people of different racial or ethnic groups. But race is not a biologic concept. Like there's no physiologic, genetic, biologic correlate of race. Race is how we perceive other people and group them into categories that's based on like their looks. And sometimes what we're really looking for is racism. It could be interpersonal racism, it could be the chronic effects of racism, it could be exclusion from the healthcare system, et cetera. And so I would suggest not presenting race as a biologic construct or like a firm category in your research, but rather representing things like racism and thinking about what association are you looking for and what is the actual variable of interest. If it's not a biologic category, what is it and how are you using it? And this kind of relationship can be more clear with sex. And so when you're talking about female, male, or intersex participants, are you referring to their hormones, their genes, the body size, et cetera, that kind of correlate with being female or being female? Like most females are smaller in size than most males, but certainly grouping people into categories as female, male, and then using body size as a surrogate like that is not going to work. For example, in your study for your association, are premenopausal females with higher estrogen ratios different than postmenopausal females with lower estrogen levels? Are those postmenopausal women more like the males in your study? Like, what is the actual association that you're looking for? And this can help with a sex and gender based analysis. And then lastly, gender. And when we're talking about women, men, non-binary people, transgender people, etc., we have to think about expression, roles, and bias. And when I talk about this, we think a lot about the work done by Colleen Norris, who's from your institution. And I always talk about her studies in this part because data that she looked at found that, there was this association between being female and having a more challenging recovery, after open heart surgery. And there was a lot of questions about, well, why would women be having more wound issues, more postoperative complications? And through her work on gender roles, her team discovered that it wasn't being female, it wasn't a body size thing and anatomy thing, but a lot of it contributed to having a caregiving role, which is a more typical role for women in our society. But people with caregiving roles, when they left the hospital, were doing more caregiving, more meal preparation, more domestic work. And those people were not healing their sternums as well, and they were having more postoperative complications. So again, if you just stop at females have more postoperative complications, you're missing a really important association that might be modifiable or might be better understood. It's also important when you're collecting your data that it needs to be accurate and sensitive. So for example, when you are asking people about their sex or gender, are you matching the correct terms? Are you using appropriate categories? So for example, you should never put other as a category. Like, can you imagine if you were a trans or intersex person and you had to keep choosing other? I'm not a man, a woman, I'm an other, I'm an other, I'm an other. People will drop out of your studies if you're asking them to categorize themselves in a stigmatizing or exclusive way. And then all of a sudden, you have all these trial data, and we're missing 1 to 3% of the entire Canadian population who identifies as intersex, trans, or non-binary. They'll drop out of your study if you're asking them to identify in a way that is not intuitive or not authentic to them. And so I really recommend thinking very carefully about these categories and ensuring that you're being clear in what you're asking about and why you're asking it. So if you care about someone's legal gender or sex assigned at birth, so the sex or gender on their administrative records, on their birth certificates, etc., ensure that you have an intersex option, because in Canada, sex is female, male, and X or intersex on all of our legal documents. And so if you have sex listed as X on your birth certificate or on your passport, what are you supposed to be selecting? Are you misclassifying yourself? Are you dropping out of that study? And so it's really important to honor people by allowing them to correctly identify. And then similarly, asking people about their gender. Do you want to know how they refer to themselves, what their pronouns are, what their gender roles are, how they might have experienced sexism or misogyny in society? And so thinking about what you're really looking for, using the correct instrument to measure that, and please provide accurate, scientifically correct, and empathetic options. And so you can say a gender not listed, for example, rather than other, would be a very nice way to put that. It's really important to consider data stewardship when you're partnering with communities or when you're doing research on or with communities, as an ethical principle. And again, knowing the history of your field here is going to be absolutely critical. So when you're looking at data analysis about historically excluded groups or marginalized groups, you might want to apply a higher ethical bar for that. So for example, Indigenous people or First Nations people in Canada have had a very terrible relationship and have experienced a great deal of harm from Canadian researchers. And for this reason, First Nations and other Indigenous groups in Canada are very reluctant to participate in research. So we've being, the academia of it all, we have performed a lot of research that has been used to justify harms to Indigenous people, to blame Indigenous people for problems imposed by colonization, and to kind of propagate a myth that Indigenous people are somehow biologically or physiologically inferior. And so if you are not aware of that type of history in your field, whether your research is in tuberculosis or in stomach cancer or on cells, if you're not aware of that history, you're perpetuating those harms, you're not correcting for those mistakes, and your partnerships with community are always going to be from that lens. And so it's very important to look at that and understanding how community ethics are different than individual ethics. So for example, when you consent a person to be in your trial, and then you analyze that person's data as part of a community, like being Black or being trans or being Indigenous, did you consent, or how did you involve that community in how that data was used, stored, analyzed, et cetera? And we think of this a lot in terms of like biobanks and genetic analysis. But I would argue, even in like qualitative studies, if you are analyzing someone's data as a member of a community, like, okay, I interviewed 3 trans people and this is what trans people think about XYZ. If you're not partnering with community in a meaningful way and you haven't considered data stewardship as a whole with the trans community, I would argue that that can really cause a lot of harm. And you're using that data to make generalizations about a community without their permission. And so community ethics is different than ethics and ethical relationships and consent with an individual. And to learn more about that, I would suggest OCAP training. So that's through the First Nations Governance Council of Canada. It's training modules about ownership, control, access, and possession of data. It's very specific to First Nations groups, but I do think it can be applied, or at least the principles should be considered when working with other groups, even if those other groups don't have like a formal committee of trans people who decides, who speaks on behalf of that community. But it can be really important then to include people from the trans community in your data sharing, your data analysis, et cetera. And so I think it's really, really important to consider. So I want to talk about knowledge translation as an ethical obligation for considering EDI in research. So I'm sure you've all heard that sort of data point that it takes 17 years for research to become a common practice. And I would ask if that is adequate. And I think we all say like no, knowledge translation implementation are very important. But in particular, if your research uncovers a disparity that's related to discrimination, bias, structural inequity, racism, etc. So if you discover that female patients are having more harms from an intervention than the male patients that intervention was originally tested in, like the ICD or cardiac trials we discussed earlier, is 17 years then acceptable? So how do you incorporate EDI in knowledge translation, and how do you plan your knowledge translation activities as an EDI or ethical obligation of your research? So it starts by disseminating your results to community. And so, optimally, you've engaged your stakeholders very early in your study design and you've been planning for dissemination the entire time, but often this can be surprising results or unanticipated results, or perhaps you just came late to the game, which happens. I would start by reaching out to national organizations or community leaders. So if your research uncovers a difference between female and male patients with Parkinson's disease, talking to the community outreach arm of the Canadian Parkinson's Society about what this might mean, and ensuring that the national organizations and community leaders have the materials they need to advocate with your results, that they understand your results, and that the results are sort of in a packageable way. So for example, if you were doing work with First Nations communities, ensuring that your results are disseminated to them in a package that they can use for lobbying, advocacy, that they can get more resources, or that they can reach out for more research partnerships. And so you don't have to be necessarily an expert, but again, thinking about privilege and marginalization as a researcher, as an academic, you already have a position where people will take you more seriously. You have that privilege or positionality, and you can leverage that on behalf of communities, even if you don't want to do the advocacy work yourself, or you don't want to do the KT and dissemination work yourself. You can partner with communities and say, hey, we found this result, we're going to publish it. Is this useful to you? In what way would this be packaged to you? Is there some way that this data can help you, starting that career? And so I just would argue it's not right to publish some major finding about an inequity or a bias in your research area and then advance your career and move on without ensuring that there's a KT or dissemination plan that can help the community where the disparity is most affecting. And so I'll quickly give you an example of how that would look in a research project with some research that I did with some residents at the University of Alberta. They had done a survey of women residents returning to work after a parental leave to identify barriers and to make policy recommendations to improve the experience of resident parents. And in that survey, one of the most notable findings was nearly all of the residents reported that they did not have adequate time and space to pump or express breast milk at work for their babies. And this is important because resident physicians typically come back to work shorter than the typical 1-year maternity leave. And the recommendations are to breastfeed for as long as possible, up to a year or longer. And so a lot of the residents were really distressed that they were not able to make their 1-year breastfeeding target because when they returned to work, they were not able to pump breast milk. And so when we reviewed the literature, we saw this was exceptionally common in multiple settings, countries, training programs, etc. And then we consulted with a librarian, did a systematic review, and found that, yeah, this was a really significant problem over space and time. And so, we published our original survey, we published the results of our review, and we get a paper. And so then, that's the study objective. It's done, like you check that box, put it on your CV and move on, hopefully get promoted, whatever your goals are. However, like, is that enough, right? What is my obligation as the PI of those studies of that work to then say, okay, we found a really important modifiable disparity. How do we ensure that this result is used in a way that benefits the people that we studied? So like I studied resident physicians, physicians in training who are returning to work at a very vulnerable time. Do I just say, well, this doesn't affect me and good luck to you all, the paper's there if you want it? And I don't think that's right. And so when we were doing our kind of scoping review, we found that there are a lot of laws that actually say in Canada, workplaces are obligated to provide adequate space and time for people returning to work who choose to breastfeed. And so we worked on disseminating that. I spoke about that fact and that we were not meeting those targets. So Alberta Health Services, which is the workplace of residents, was not providing adequate time and space for moms wishing to breast or chest feed upon return to work. I did presentations, I made data packages, I emailed people, I called people from AHS. You know, I really went like absolutely bananas, like full force on this lactation space. And eventually, Alberta Health Services did write a lactation policy whereby they committed to ensuring adequate space and time for all AHS employees by 2024. The issue was that this policy went into effect, I think it was like February or March 2020. So it was literally immediately overshadowed by the pandemic and the healthcare system collapse that came with that and the entire disruption. And so they created a policy and we have not yet implemented or done a lot of work or accountability around that. We're kind of touching base now, but of course then AHS, we reconnected in October to start talking about, okay, how can we operationalize this policy or socialize this policy now that things are settling down? And then now there might not be an AHS in like a month. So anyways, all this to say is there's been a lot of like contextual things that have been in the way of this. So as I tell you how important and ethical it is, I can also tell you that in some ways we've kind of come up short. But if you want to learn more about some of these topics as an individual, what can we do starting today? We can take implicit association tests to understand how our biases may come up in our work or in our day-to-day interactions. You can take bystander intervention courses for free, and that's for practicing the skill of interrupting harassment, discrimination, bias, racism, etc. when you see it. You know, taking into consideration that a lot of people don't like conflict, or a lot of people might be sort of junior in the whole hierarchy of academia. And so it can be really hard to put your foot out there and say, hey, you can't say that, it's racist, but gaining skills and other methods for how to address these issues when you see them that are not necessarily confrontational and do take into account the hierarchies and things like that. You can learn Indigenous history in Canada. So a lot of the things I spoke of today and things that we're becoming aware of is that we didn't necessarily learn about residential schools and the history of colonization and oppression and its effects today for Indigenous and First Nations people in Canada. And so relearning that history, your institute, the University of Alberta, has a free online course about this that can be really helpful. You can learn and practice anti-racism. So Anti-Racism Daily is a newsletter that takes the events of the day, like what's in the news, and applies an anti-racism lens to them to show you how the practice of counteracting racism and interpreting information, considering the history of racism and oppressive systems, can be done. It's important to consider sex and gender in your work, and I think this is becoming more and more to the forefront of our minds with, you know, CIHR guidelines and things. But even thinking about your data intake forms and what exclusion of sex and gender minorities can really do to your research, I think is important. Using bias-free language is critical. If you're a member of a marginalized group and you hear stigmatizing language, you disengage from research because you know it's not going to be a safe place for you. And we're excluding a lot of people in that way. And then I referred to the OCAP course earlier about data ownership and data stewardship and how that can help you be more ethical considering community involvement in your research. And so this is just a short presentation about how these things can be done. So if you have any questions or comments about this work, you can always email me, or we can chat about it now, because I know it's a big big topic, and there are a lot of limitations to being able to do this well, but I'm happy to discuss this.